thanks. It's great to be here. Sorry for the AV difficulties. But if you have any questions during the talk, just stop me, and if you want, or if I'm going too fast, slow me down. So just a little overview of what you can expect with thyroid eye disease. We're going to go a little bit through the course of the disease, the association with the thyroid gland, some of the clinical manifestations, and then management of the active phase. And then we'll talk a little bit about the multidisciplinary thyroid eye disease clinic that we have now at Jules Stein as well. So a lot of patients come in to see us and they're kind of scared as to what can they expect with the eye disease and what their course is going to be like. And we don't really have a crystal ball or any markers that'll tell us whether or not you'll have mild, moderate, or severe disease, but luckily most patients have mild to moderate disease, and only a small percentage of patients have very severe disease that we have to do something about it. And just like you know, you're not alone. And there's lots of people around the world that have thyroid eye disease, and there are even prominent public figures that have thyroid eye disease, like Barbara Bush, and I think even President Bush has a little bit as well, as some of the stars, singers, songwriters have it. So a lot of people are dealing with it, and there are ways that we can help you. The good thing is that the thyroid eye disease seems to be self-limiting. It's usually about 2 years or so in the active phase of the disease, and then it tends to stabilize. We went over a little bit about what Graves' disease is, but what does it really have to do with the eyes? We know that it's an autoimmune disorder that attacks the thyroid gland, and somehow it's related to the eye disease. And Dr. G went over a little bit about the symptoms of having a hyperactive thyroid gland with having nervousness and irritability. Your heart starts to race, you lose some weight, and maybe you perspire a little bit more. So, but why does it, what's the relation to the eye disease? Well, it can either happen before the eye disease starts, it can happen after the eye disease starts, or the eye disease can be related to no abnormality in the thyroid. So we call that euthyroid eye disease. So really the diagnosis of thyroid eye disease is a clinical diagnosis. We don't really kind of follow the labs or the TSIs, but it's very important to keep your thyroid normal during this time. So you need to build a relationship with your eye doctor as well as your endocrinologist so that we can keep the thyroid axis normal. And especially when you're going to maybe take on ablating the thyroid gland, if you have some mild signs of the eye disease, it's important to let us know that you're going to have this done so that we can follow you a little bit more closely, maybe put you on some steroids to try to help suppress the immune system right around that time. So why the eyes and why the thyroid? Why are all of these related? Well, we've found out that there are receptors in the eye tissues that are very similar to those found on the thyroid gland, and I think we went over that yesterday. But the symptoms that are associated with it, with the eye disease, are kind of more discomfort, swelling in the active phase of the disease, more dryness, and puffiness. So a lot of patients are bothered symptomatically by all of these changes, as well as the changes in their appearance. Some patients don't want to go outside or be seen in public during this time because the eyelids tend to retract and open a little bit, and the eyes start to come forward in some patients. A lot of patients also have some blurry vision, mostly because the tear film dries out, and that's important in the refractive or the way that you see the world, is that you need to have a nice smooth tear film, and once that breaks down, things start to get blurry. If the eye muscles are involved, you can also get double vision where you see two of one object, and it's not necessarily all the time. It can start happening intermittently. So if that starts to happen, you need to let us know so that we can follow you a little bit more closely and maybe put you on some medications to change a little bit of the immune system. Also, a lot of patients get a pressure feeling. Even if they don't have the eyes coming forward, the pressure feeling can be a combination of the tissues being more swollen, but also the dryness of the eyes can also cause this pressure sensation. So it's important to let us know so that we can kind of work with you to adjust some of these symptoms. And what do we see clinically? What are the manifestations of thyroid eye disease? Well, you guys know that it can affect the muscle and the skin and the fat, and all of those around the eye socket can be affected. So you can get redness and swelling of the eyelids that can vary. So we ask that, you know, if it's really mostly the swelling that you're seeing, maybe you can avoid a little bit of salt, because salt makes you tend to retain a little bit of fluid. And the redness of the actual eyeball itself are an indication of being in the active stage, as well as redness of the eyelids, both the upper and lower eyelids. The fat tends to enlarge, as well as the muscles, not only behind the eyeball, but also around the eyeball, in the eyebrow area. You know, people tend to have a little bit more fullness here, as well as the muscles start to get a little bit bigger, and some people say, oh, I just look angry all the time because of that change. And it's not because of you doing anything, it's because the disease is affecting the muscles and the fat around the eye. A lot of patients with mild disease just have eyelid retraction, where the eye is a little bit more open. One side can be a little bit more open than the other side, and this is a big cause of the dryness being a factor, because the eye is more open to the air, the tears tend to evaporate a little bit more, so you have a little bit more dryness on that side. In addition, with the eyes coming forward, because the muscle and the fat get a little bit bigger behind the eye, that can also cause the eyelids to open up a little bit more, and also cause some dryness of the eyes. So that's another reason why it's important to treat the dryness that you're feeling. Some patients have a little bit of restriction in the muscle movement of the eye, and so there's about 6 muscles around each eyeball that control the eye movements, and any one of them or a combination can be affected. So that kind of makes you a little bit uncomfortable in certain gazes, and how you see, and maybe some blurred vision. And fortunately, vision loss or changes in the vision are rare in patients with thyroid eye disease, and we call this optic neuropathy, where the muscles and the fat get so big that it puts the some pressure on the optic nerve, and also makes the optic nerve a little bit tight, and it stretches it out. So we have to be cognizant of that. Now keep in mind that both eyes don't act the same, and we don't really understand why. So one side can have more changes and the other side can look completely normal. So it can be very asymmetric, and it can also get better a little bit and then get worse. And why it happens, we're not really sure. We think that some of it is related to the thyroid function, but sometimes it's not. And the eye disease could happen, you know, 20, 30, 50 years after the thyroid disease. So it's always important to keep a handle on what kind of symptoms you're starting to have. So we'll mainly focus on the treatments in the active phase of the disease, because this is where we have to kind of be patient and watch what's going on. And there's things that you can do, and there's things that we can do as physicians. So it's kind of an interplay. You have to let us know how you're feeling so that we can adjust everything for you. So let's first focus on things that you can do as a patient. And you know, I was seeing patients this week, and I was asking them, oh, what do you think is the best? So these are a little bit taken from my patients that I've seen, and they said the most important thing that you can tell anybody is to be patient with the disease. And I think that's important, because things are always changing and we don't want to do things too early because we can make the disease a little bit worse. And you know, the active phase is about 18 to 24 months, and that's a long time, especially when your eyes are changing and you don't know what's going on and you're stressing out. But it's really important to be patient during this time and communicate with us your symptoms and how you're feeling. And there's 3 basic things that you can do. And the first one, which is most important in the eye disease, is to stop smoking. And it's really important. We think that it makes it worse. We're not exactly sure the mechanism, but we have seen that the disease is actually worse in smokers. And it is a stressful period of time. Some of my patients have used hypnosis to stop smoking, or the patches, and it has been helpful in their disease. And also, you don't want anybody around you smoking, because secondhand smoke can also make it a little bit worse. Dr. G also mentioned that stress can also be a trigger, and it's important to kind of try to lower your stress during this time. And it is a very stressful period of time because everything's changing and you don't know what's gonna happen. But it's important just to stop, relax, go outside, smell the roses, go pamper yourself, go get a massage, or whatever you do to relax, because the good thing is that it's self-limited. So it'll be, you know, that few months, and then we'll focus on getting you better. So it's important to kind of keep that perspective in mind, because some diseases, they just go on forever and they just keep getting worse. But this one is self-limited. The next thing that you can do is have a healthy lifestyle. And this includes exercise. So don't just sit in your house and sit on the couch and watch TV and avoid the world. Go out, be active with people. You know, join a yoga class. It's good for both, you know, lowering your stress level as well as getting good exercise. So a lot of my patients do this. It's also important to eat right. So you want to eat less crap and eat more food. So you don't want to eat, you know, a lot of processed foods or things with refined sugars. You want to eat more healthy foods. So we tell our patients this, and they tend to try to change their diet. And it's really important. And there is an anti-inflammatory diet that you can do, which is based on fruits and vegetables, the berries and the antioxidants in the berries, and then the omega-3s. So you can look online, and there's a book on it. So some patients think that it really helps, and it may. So I think anything that you can do will help. And we briefly touched on selenium in patients with mild eye disease. There was a study in Europe that showed that maybe it can help prevent the progression of it. So we do recommend that our patients take selenium if they have some signs of thyroid eye disease. And that's 100 micrograms twice a day. You can get that in your Whole Foods store or order online. It's pretty widespread. There's no specific brand that you need to use or anything. And the last thing that you can do is make your eyes feel more comfortable during the active phase. And during the day, that means applying eye drops. And I tell my patients, every time you put something in your mouth, put a drop in your eye. So it kind of reminds you, you can do it breakfast, lunch, dinner, and bedtime. That's 4 times a day. If you find that your eyes are a little bit more irritated, especially when you're reading or using the computer, that's normal, because when you're doing those kind of focused activities, you tend to blink less. So you need to take breaks and put a drop in, and because you stare at the computer, and it's been proven that your blink rate actually goes down. So just sit back, put a drop in, wait a little bit, go back to your work. Okay? And if you find that you need to use drops more than 4 to 6 times a day, it's a good idea to use a preservative-free kind of eye drops. Those are the ones not in the bottle, but you break off the top and you put the cap back on. And you can keep it for about 24 hours and then throw that one away. At nighttime, especially if your eyes don't close fully, it's nice to use an ointment because it keeps the ocular surface lubricated during the night. And if you find that that's not enough, the next morning you can add things onto that, like something that we just tell our patients because it's easy and cheap is use a saran wrap dressing, where you get a tube of Vaseline, put a little bit around your eye on the bone part, cut out a square of saran wrap and stick it on right after you put the ointment. And it actually works really well. You could also try to tape your eyelid closed at night. Sometimes that's a little precarious and everything, but this actually works. It may sound a little bit silly, but it actually works pretty well. The other thing you can do if your eyes are really irritated is at nighttime you can get these Tranquilize. You can buy that online, and it has a foam covering so that it keeps the moisture in, and then during the day they have these special eyeglasses that have foam around them as well that keeps the wind out, so that if you're finding that when you go outside your eyes are more irritated, this may be a good idea. It's called Optics. You can get it at any eye shop. And then finally, a lot of patients ask, well, which brand should I get? It doesn't really matter, I don't think. Just find the one that feels good to you. They're all different brands, all different companies. And I just tell my patients, if you have a coupon, use it and try it, because they are expensive drops. And each one is a little bit different. They have the thinner version, they have a thicker gel version, and they have the ointment version. So there's all different kinds, and it's very confusing when you go into the drugstore. Which one do I get? Well, pick one, try it out, see if you like it. If you like it, stick with it. If you don't like it, switch to another one. There are different methods of the preservative in each one of them. So some people are allergic to some of them, so there are some that actually dissolve, like Optic, that one dissolves on contact. So just try them and see which one works out best for you. If your eyes are really dry and nothing's working, and your eyelids are a little bit higher above kind of the colored part of the eye, there are some things that we can do for you. We can do a little bit of an injection in the upper eyelid, in that muscle that lifts up the eyelid. It tends to get tight over time. So we can put a little bit of this filler there, which can be dissolved easily, and to lower the eyelid. And a lot of patients get a little bit of comfort out of this, and they can close their eye just enough so that they're comfortable at nighttime. So if that's happening, then just let us know and we can try this. And if you don't like it, we can dissolve it out with an enzyme. We just do it in the office. It's pretty easy to do, and it works. The next thing that a lot of patients have to deal with is the double vision, which can be very distracting and makes you not feel good, especially in the morning. A lot of patients have a few hours that they have to adjust, and their eyes kind of realign during that time. And this is because the muscles tend to get bigger and they get stiff, and they tend not to move as well. And for us, the most important vision is the straight ahead and downward, so that you can reach, so you can function. So as long as you have good single vision straight ahead, then we ask that you kind of posture yourself when you're driving or something to turn instead of move your eyes, because that's one thing that you can do. For surgery, we'll talk about a little bit later, if you have good vision straight ahead and then down, we won't necessarily recommend a surgery for the different gazes. If you are having significant double vision that's bothering you all the time, constantly, then we can put on temporary PRISM glasses. We customize them, we measure you, we cut them out and put them on the glasses temporarily. And then a lot of patients function just fine. But with these and with the double vision, it can be a little bit tricky with your depth perception, especially when you're driving, or if you tend to cover one eye. The depth actually is from both eyes seeing the object. So just be careful. If you're driving and covering one eye, you can. It's legal to do that, no problem. But just be careful about how far away you are from the cars. And you may just want to you know, for a period of time, just relax, have someone else drive you, so if you can, because the depth perception takes a little bit of time to get used to when you're having the double vision. Other things, I think they went over this yesterday about the different therapies that can be done in the active phase. If you are progressing and things are getting worse and your symptoms are getting worse, sometimes we can use medications that kind of decrease the immune system function. The main one is the steroids. They do have some side effects, but we can monitor you closely and see if this actually helps some of your eye symptoms. In the future, we want to kind of figure out what the markers for the eye disease are. We haven't done that quite yet, but we're on our way to doing that. And with these different therapies, we can calm down the immune system from attacking the tissues. And the main goal is to make you feel more comfortable, and we hope that we can target the individual receptors one day that are causing the eye problem specifically. And a lot of patients, I don't know if you've heard of this, but we've tried Rituximab, which is an antibody to the B cells, which produce antibodies in the body. Some patients that are kind of very severe will try this, but this is in a very rare case. Maybe we use it, you know, less than 10 times a year on patients. Other therapies can also be used, but hopefully one day our goal is to use these different therapies so that we can avoid surgery and avoid the eye disease from starting in the beginning. So that's kind of, as physicians, that's our goal, is to kind of figure out what's going on so that we can prevent it. And because right now what we do is we kind of get you through the active phase and then we do the surgery afterwards. So what else can we do for you as doctors? Well, we do need to better understand the thyroid eye disease and prevent it. So it's great to have organizations such as this so we can get your feedback and figure out what kind of questions you're having. And there's also a group, the EYELIDS group. It's a network of physicians that are interested in thyroid eye disease so that we can better kind of figure out what's going on. We've also formed a multidisciplinary thyroid eye clinic at Jules Stein with a rheumatologist, and we're talking to some of the endocrinologists as well. And it's based around patient support and education so that you can kind of learn a little bit more about the disease. We have an afternoon where we just see patients with thyroid eye disease so that you can talk to other patients and ask us questions. And there's lots around the US, so Michigan has one, UCSD, so you've heard about all of these places, and maybe there's one closer to where your hometown is, and you can go see them. And really, we focus on, you know, making sure that you understand the disease, get all your questions answered, sit down with you at your initial visit, give you all the literature that we have so that you can kind of feel more comfortable and put your mind at ease about things. And I just have a short little video from, it's not gonna work.
Yesterday, yeah, he pulled the mic out and held it up against the.
It helped to know that these two were experts.
I don't think this is gonna work. Well, anyway, it's probably gonna not work, but you know, we have our patients that come in and they see us in our clinic every month while they're really active. So we have it once a month, and then once you kind of get a little bit less active, we'll space out the visits. So in the beginning, when you're active, we try to see you often so that we can figure out if you're getting worse quickly, and then we'll start you on different therapies, or if you're doing okay and you're not really changing much, then we'll space it out to every 2 months, or then every 3 months, and when you're really doing well, every 4 months. And then once we get to a stable phase in 6 months, then we say, okay, you're not changing, what do you want to do? So that's kind of what you need to prepare yourself for when when you need some treatments for the eye disease. In addition, we are starting a clinical database for our patients with thyroid eye disease so that we can better understand the disease and help guide our treatments and figure out which drugs work and which drugs don't work. We've been using a few different immunosuppressive medications that we think may be beneficial in the thyroid eye disease part of the disease, because steroids long term are not very good for your bones and for your body. Ultimately, we want to set up a network of thyroid eye disease clinics around the world so that we can share data and figure out what's going on and also start clinical trials. And right now we're getting IRB approval for a few of them, including the one where we use the filler in the upper eyelid to try to lower the eyelid, because I think that it does something else, and it maybe over time you may not need the eyelid surgery. So I've had a few patients where they're young enough and we do it in the active phase, and then they come back 10 months later and they look fine, they don't need anything. So I think that something is going on. We are also doing some quality of life surveys and seeing how it impacts your life. So in summary, for what you can expect with the eye disease, well, it's probably going to last somewhere around 18 to 24 months, and it can be a roller coaster at times. I mean, you'll come in, you think that you're doing worse, and then we say, oh, well, we put your pictures up side by side. We'll say, oh, well, it looks about the same, you know. Or yes, you're getting a little bit worse, let's change some stuff around, change some of the therapies. But together we can get through this, together with all of the different doctors that you work with. We communicate pretty well with each other, but you need to tell us what kind of symptoms you're having so that we can help you. And important to just be patient during the active phase of the disease, and just know that there are some things that you can do to make yourself feel better and maybe calm down the eye disease portion, including not smoking, having a healthy lifestyle, using eye drops, and you know, it's self-limiting, so it will stop. So that's it. Thank you. Yeah, we can take questions in the back.
Can I see your selenium slide again?
Mm-hmm.
Is that possible?
So that's 100 micrograms twice a day. And there's no specific brand that you have to use. And
I've got a comment on that.
yeah.
Most multivitamins have selenium, oftentimes 200 milligrams. So if you look for a multivitamin that has 200 milligrams, I don't know if it's necessary to take it twice a day.
No, you can do that. So if you're taking a multivitamin, yeah, that's right. Just make sure you're looking at what it actually has. I don't think you can really overdose on selenium, but I'm sure you probably could, because too much of anything can't be very good.
You had a box indicating psychosocial support. Could you say more about that? Who provides it?
So we have a nurse in our clinic. She's actually a Reiki Zen, certified Zen person, so she can help you with ways to kind of decrease stress, methods that you can use. Like there's different scents and that aromatherapy that you can use to kind of relax yourself, like lemon or lavender. So she'll go through that and your diet, and then there's a lot of patients in our clinic that are willing or who would really like to talk to you if you have a lot of questions about the disease and what to expect. People that have been through the surgeries and the rehabilitation, they offer up to be there for any other patients to kind of support them and what to expect and how it is going through the different stages of the disease.
For some patients, they become desperate if they are at the
Worst,
end of
yeah.
the continuum with eye disease, and they need really sophisticated help to get through this period of
That's
time.
true. That's true.
How do you arrange for that?
Well, if they do want kind of a therapist, we can put you in touch with some of the therapists in the area.
So you refer?
Yeah, we'll refer. Yeah.
Some of the nighttime ointment, I was reading the ingredients and it says just petroleum in it, but it's like smaller than my pinky and costs over $10. Is there any way to like use regular? Is that not a good idea?
It's not a good idea because of the different filler products that they put in it aren't really safe for the eye. That's why.
I didn't hear you say anything about Restasis. Did you prescribe that very often?
So Restasis is a twice-a-day medication. In some patients with dry eyes, it helps, but it takes about 3 months to kind of see the effect. And a lot of the patients complain that it burns when they put it in. So personally, I don't recommend it unless they're at their wit's end and they just want to try something. It's not a first-line agent that I try to use just because sometimes it works and sometimes it doesn't. So.
What role does the rheumatologist in your group play?
So the rheumatologist is kind of an expert in autoimmune diseases, and they kind of help us immunomodulate, use the different medications and guide therapy, and monitor your blood levels, make sure you don't have side effects from it. He comes with us and evaluates every patient in our clinic, and we thought that it's a good idea because we work very closly with the endocrinologists, and we're trying to get one that might want to come over during our clinics, but it's more important for them peripherally, to control the thyroid. They don't have to be with us at that exact visit, but the rheumatologist is there so that we can change therapy that day if we need to. So we don't need to go back and forth and say, hey, go over, see that, the doctor that adjusts your therapy and then come back. There are some eye doctors that will kind of monitor and adjust the immune therapy, but we think that it's better that the rheumatologist does it because they're more attuned to all of the side effects than we would be. So that's what they do on a daily basis. They put patients on all of these different immunomodulators, and then they get samples, and so from the drug company, so it actually benefits our patients because they'll get free drug. So it works pretty well.
Could you please address the state of the art or lack of the state of the art in grafting the hard palate to the lower eyelids?
So we'll talk a little bit about the surgery in the next section, but it's difficult because we have to wait until the disease is stable before we do anything, because we may set off the disease and make it worse if we go too early. And the hard palate grafts, basically it's a spacer graft, and it takes up that space because the muscle gets very tight and pulls the eyelid down, and then that hard palate graft is there to take up that volume. And it usually shrinks a little bit over time, and you may need multiple stages, but it's kind of one of the things that we can use. It's not the only thing that we can use for eyelid retraction, but it's one of the things that we can use. So.
Do you see much mapped out fingerprint along with the thyroid eye disease?
It's not really one-in-one. Map dot is very common in eyes in general, and it's not directly related to the eye disease. So it just may be coincidental that you have those findings in your eye. But map dot fingerprint, you find it and you kind of make sure that there's no erosions after a while and just follow it closely. But it's not really an indicator for the eye disease.
And if someone's having frequent erosions, then where do you go from there?
It depends on why they're getting erosions. If it's from the dryness, then we have to treat the dryness. If it's from the eyes being open and it being rubbed on the pillow, that's another mechanism that we have to deal with, like with eye shields or different methods. And then the specialist in the front of the eye can do a procedure where they kind of do little needle sticks to make the tissue stick down, and then there's different medications that we can try to make the cells kind of stick down a little bit better. So there's all different factors and things that we have to look at why the erosions are happening, and then treat that.
You mentioned several times the 18 to 24 month cycle of disease. How does that vary in patients? Is there a lot of variability in that?
There is a lot of variability. That's why we tell you that, because that's kind of the maximum, but it can be shorter. And we like to see that you're stable for at least 6 months before we do anything. And a lot of patients don't even have to have anything done, but some of them just need a few things done. So we tell you that to prepare you for the worst, but it's not always a full 18 to 24 months. It could be in a rare case, it could be longer, and it can reactivate, several years down the road. So it's important to kind of follow with us when you're stable on at least every 6 months to begin, and then every year after that, just to make sure things don't change. But for the most part, the majority of patients have one bump, and then they don't have a reactivation.
Does the eye disease cause other conditions such as like torn retina, or is that a completely separate thing that could happen simultaneously?
Yeah, that's separate. There's no proven inner eye problem related to the thyroid eye disease. It's mostly the tissues around the eyeball that get affected, and not really inside the eye.
Where can we get a good listing of the anti-inflammatory diet?
I just went online. There's a book. You can buy it, but online they'll outline. It's mostly based on antioxidants, so lots of blueberries and raspberries and vegetables like kale and spinach, so green leafy vegetables. And I forget who wrote the book on it, but there is, if you just Google anti-inflammatory diet, you'll find it.
When you talk about stability, are there, and say diagnosis clinical by the symptoms, are there objective measurements at all that are used to say, okay, this is start and onset and reach the stable state, or is it just how the patient is experiencing that?
So we have measurements that we use as physicians to kind of track you. I didn't really go into that depth, but the exam's actually kind of long. So vision, making sure everything responds properly, making sure you can see color. We do measurements from how far the eyes come from the bone. So we follow all of those, and then we take pictures every time so that we can put one up next to each other and see how much swelling there is, and we have a grade for the swelling and the redness for all different parts of your eye. So we kind of do that, and it's a fancy score that we can give you, but basically, we can follow you when we see you every month, and we see you every month, we can kind of tell, but we do actually do measurements as well. So.
Generally speaking, about dry eyes, does flaxseed help?
So dry eyes can be due to a lot of different things. So flaxseed oil is one of the components, or one of the things of the tear film. So there's different parts of the tear film, and there's different reasons why people have dryness of their eyes. So the oils are thought to help coat the outer surface of the tear film so that they don't evaporate as quickly. So if that's the issue, then flaxseed oil may help with your eye disease. If it's because your actual gland isn't producing the tears, then the flaxseed may not help as much, but it's not going to hurt. So I would say if you have dryness of your eyes, just to take the flaxseed oil. It's not going to do anything. It will thin your blood down a little bit, so you may notice more bruising. But I take flaxseed oil, and I think it helps my dry eyes, because most people living in California have dryness of their eyes, because it's just dry. Yeah, and then other things that we can do, we can put plugs in the tear drain, because there's 2 holes on the eyelids that lead into the nose that drain like a sink. So if you put a little plug in there, sometimes that'll help retain the tears a little bit longer. And we can do that in the office as well. So.
What about the omega-3 oil?
Very similar, so you can use that. Whichever one that you like better. You don't need to overdose on any of the drugs, but flaxseed oil is just something that we say is easy to do. You can just add it to your salad if you want. They have it in little pill forms as well. Some people don't like the fishiness of the fish oil or the omega-3, so that they take flaxseed oil. So, and that's the main reason.
When you have a reactivation of a thyroid eye disease years later, whatever, do you have any idea? Is there any difference in the etiology?
We're not sure why some patients get reactivation of their thyroid eye disease. We think maybe it's due to stressors. They'll usually report some sort of stress trigger in their life, or the thyroid functions have kind of bumped up or gotten a little bit out of hand. So that's why it's important to always try to keep your thyroid levels under control, because it's not directly related, but it is correlated with the thyroid function. So that's usually the case. And the reactivation is very rare, but it can happen, but it's very rare.
Are there any contraindications in having any corrective eye surgery like LASIK or Diplomate when you have 10 eye disease?
I would not recommend it, just because. So when you have thyroid eye disease, you have dryness of your eyes. If you're okay with the dryness and your eyes aren't very wide open, then maybe you could do it. But the thing is that those types of eye surgeries can make your eyes dry or make them feel dry. So it's kind of a risky thing to do. I mean, it won't be the worst thing, but if you can live with your vision the way it is, I wouldn't mess with it. You don't see if you go to a lot of different eye doctors' offices, you'll see a lot of them still wearing glasses. So.
I have a comment on that. I've always been told that now needs to put the LASIK stuff down. You can't have it. But he said when I got my cataracts out, it would be like having LASIK surgery.
Exactly.
So I said,
Yep.
all right.
Mm-hmm.
It is.
Is it? Okay.
Yes.
Yep. Yeah, so if you need cataract surgery, then you can have that done. But the LASIK is a little bit tricky for patients with dryness, not just for thyroid eye disease, but for patients with dry eyes. I wouldn't recommend it.
During the active phase, how much should we be avoiding things that make us have allergies, or should I get rid of my cat? What? Just for your...
No. I don't. You're allergic to your cat?
Yeah, I love her very much, but I do know that if I'm petting her or she's crawling up on me, my eyes will start to itch and water.
Well, allergies are kind of part of the whole, immune system kind of telling your body that something's not right and that's a trigger. So maybe you want to just treat your allergies during that time, and if you find that your eye disease is getting significantly worse, then maybe consider. But I mean, having a pet around is soothing and relaxing and nice, so it might be too much of a stress for you to get rid of the cat. So I would just
I don't
keep
want
it.
to get rid of her. I've been
Yeah.
eyeing her wondering as my eyes are getting worse though. I need someone to blame.
No, but I would, you can take anti-allergy drops, eye drops, and also pills. So that may be enough.
Did you say how much flaxseed oil a day you recommend?
There's no tried and true recommendation, but I think it's 1,000 units. But it'll say on the bottle, whichever one you choose.
And how safe do you think it is to do Botox
Oh.
on your forehead if you have that angry look, or if it's like pulling your forehead muscles are pulling on your eye.
I think it does. That is fine. And we'll actually talk a little bit about that in the next lecture, but it's fine. It's fine.
Is there, I had orbital decompression, radiation, and all this kind of thing. The surgeon that I had was really good with the follow-up with CT scans and the visual field tests and things like that. Is there a need to continue that if everything's stable?
No, no. So we'll say, you'll see in the next section that we generally only get a scan if we have a question about what you have or if we're preparing for surgery. So once you've had a scan and you've had surgery and you're fine, there's no need to have any more scans. It's more radiation for you and more, you know, out of pocket. So there's no need.
Again, the reason I'm asking is because the first orbital decompressions did not work, or the muscles got
Right.
had more compression on my optic nerve.
Yeah. If
And they went in and redid it, and then it still failed. So I had a series of 10 radiation treatments. So I think maybe that was why they were being a
Yeah.
little approved
Right.
with the scans. But at this point, unless I would become symptomatic, there would be no.
correct.
Okay, thank you.
Yeah. Any other questions?
Have you had any patients that are inactive, you've done surgery, became active again, and need surgery?
Yes. Yeah. Rarely, but yes. But usually, if the patients that reactivate tend to have had more severe disease to begin with, so we follow them more closely anyway. So if they do reactivate, we get them pretty early, and then, you know, of course, if they need more surgery, then we'll do it for them. But don't worry about that. Good. So we'll move on to the next talk. Let me get that up. I have a little bit of a cold, so I apologize for my voice. So now we're going to talk about surgery. So we talked a little bit about the active phase and what we do during the active phase. That's mostly medical management. And then once you stabilize for at least 6 months, we can talk about surgery. And that's what we call the stable phase of the disease. So we'll talk a little bit about why, or if, the reasons why you would have surgery in the active phase. And then we'll talk about the different steps during the stable phase. And then finally, how to prepare for surgery. So surgery in the active phase is only if you're losing vision. We call this optic neuropathy. It's where the visual function decreases, where the colors start to change. That's why we ask, if you're very active and you have very severe disease, we'll ask that you cover one eye at a time and check your vision and make sure that it's not different than before, and then make sure that the red color is the same. The red is kind of the best indicator for the optic nerve function. So we just say, you know, take a red pen, cover one eye, look at it, cover the other. If it's the same, great. If it looks a little bit duller, like the slide on the left, then we call that the red kind of desaturating. So that's when we have to follow you more closely, and we may need to put you on more medications, maybe high dose steroids. And if that still does not work to keep the disease at bay and you're still losing vision, that's the only time we would do surgery in the active phase of the disease. And that's where we create a little bit more space for the optic nerve, because what's happening is that the muscles are getting big and the tissues are getting swollen and putting a lot of pressure on the nerve. So the steroids help to calm down some of the swelling. But then if that's still not enough, then we just make more room in the eye socket. So that's about the active phase. And of course, we follow you very closely during this period of time, every 1 to 3 months. And then once you're stable for at least 6 months, we can think about surgery. And again, we don't want to do it too early because we don't want to reactivate the disease. And there's basically 4 steps or stages that we go through. And we do it in a certain order because one affects the other. So the first stage is orbital decompression. That's where we move the eyes back if you need them to be moved back. The second stage is the eye muscle surgery. So if the eyes are further out, then maybe it's making the eyelids more open, and it may change the orientation of the muscles when you move it back. That's why we do the muscle surgery second. And then at the same token with the eyelids are kind of connected to some of the eye muscles. So if you move the eye muscles around, the eyelids would maybe change position after muscle surgery. There are some cases that we can do a little bit of both at the same time. Usually the decompression and the eyelid surgery. We can do the first stage of the eyelid surgery with the decompression if you have really bad retraction where they're all the way up and you're very uncomfortable. So we can consider doing that. We do that in some patients. And each step is customized for you, and you may not need everything. So you may not need any of it. You may just need eyelid surgery. You may just need eye muscle surgery. So it all depends on your measurements and your comfort level and what you're feeling. So the first stage, orbital decompression. So we do orbital decompression to basically create more space for the tissues that have become a little bit larger with the thyroid eye disease. And what happens is that both the muscles and the fat could get bigger and enlarged, and the eyeball is being pushed forward, and the swollen tissue can cause some pressure pain that you're feeling. So the decompression not only deals with the eyes being pushed forward, but also that pressure pain sensation, because a lot of the veins can be congested, and so by making a little bit more space, those veins can decongest and then give you a little bit less pressure feeling. So that's kind of why we do decompression surgery. And of course, not all patients need it. Some patients don't have their eyes bulging out, or they're comfortable and they just have eyelid retraction. But the main goals of orbital decompression is to reduce any of the pressure pain, some of the congestive signs like the redness of the eye that stays after the active phase, and then the bulging. And we mentioned briefly, we get CT scans or MRIs in preparation for surgery, or if we have a question about why these changes are happening to your eye. So which wall and how much? You've probably heard about 1 wall, 2 wall, 3, 4 wall decompression, and it doesn't mean a lot to you, but to us it's kind of it tells us how much we need to get your eyes back. Will kind of determine which ones we'll do. And different surgeons have different algorithms, different walls that they like to do first versus second versus third. But the first wall, usually for everyone, is the fat. And that's where we just take out some of the fat that has enlarged from the disease to kind of decompress and move the eyes back a little bit. The second wall that we like to do is the outside wall, the lateral wall out here. And then the third wall is the medial wall, and the last wall that we will do is the floor. And depending on how much your eyes are out, we'll kind of recommend which ones to do. And usually most people just need the fat or the fat and the lateral wall. Rarely do we do both, but we will if you're having significant symptoms. And the reason why we prefer the lateral wall is that, one, it has less risk for double vision afterwards, because the medial wall is right next to one of the muscles that controls the eye moving in. And so if that gets kind of displaced into that new opening, it may change the mechanics of the muscles a little bit more, make the double vision a little bit worse. So most patients will recommend doing the lateral wall first. And also we can do it through either a small eyelid crease incision or even just through the inner part of the eyelid. And basically you can see here that the space is a little bit more. And the medial wall we reserve for either, again, during the active phase if the optic nerve is being compressed, or if the eyes are further out and we need to move them back a little bit more, we'll use the medial wall. But there is a slight increased risk for double vision after that surgery. So what do the incisions look like? Well, we've come a long way. You know, back in the day, they used to open up the entire head and pull it down, or go through the mouth and take out the lower part of the eye socket, or take out the whole outside rim here so that the bone wouldn't even be there. But now we have smaller incisions that we can use, and people really won't even see the scars. We use the natural eyelid crease here on the upper eyelid, and then we can also use the inner part, the covering of the eye, to access the inside wall, and then even underneath to access the inferior lateral, or the outside portion of the fat. So there's all different incisions that we can use now so that it's cosmetically pleasing as well. And we typically like to do one side at a time because we don't want you to have, you know, blurry vision in both eyes with ointment in both eyes and you're disoriented. We typically do one side at a time, maybe wait a week or two between each of the stages of decompression, and then that allows you to have a little bit more freedom with your vision. And then here's a patient who had a transconjunctival decompression. She just needed 2 millimeters of volume taken out so that the eye could be set back a little bit more. And you can see on the right side that the eye comes back a little bit. And you can't really tell that she had decompression surgery because there's no scars on the outside, it's all on the inside. And another patient here, she had the same sort of decompression and also the eyelid surgery at the same time because she didn't have as much proptosis, or the eyes coming forward, so we could do a little bit of the eyelid surgery at the same time. So it's always customized to the patient as to what we can do at the same time. This patient also had retraction, but a little bit more proptosis, or the eyes coming forward. So we just did that first because we didn't know where the eyelids would be afterwards. And afterwards it came back enough and the eyelid relaxed, so she didn't need eyelid surgery after that. And here's a more severe case where she had both an outside and an inside wall decompression and the eyes came back. So how about the next stage? So the first stage is decompression, the second stage is the eye muscle surgery. So the eye muscle surgery is done second, again, because the decompression can change the orientation of the muscles, that's why we do it second. And the main goal is to create a single tunnel of vision for you when you're looking straight ahead and when you're reading. So those are the most important gazes for us to make sure that you have single vision in. If you're just having double vision when you look to the left, if we correct that, it may not be single when you look straight ahead. That's why we say that these two gazes are the most important, straight ahead and down. And we work with an eye muscle specialist sometimes that does this, or we do it ourselves. So different people do it different ways. But the majority of patients, when you're an adult and you're cooperative, we do eye muscle surgery on these adjustable strings, so that after you wake up from anesthesia or the next day, we'll actually adjust a tiny bit the muscle position. We'll set it at a certain place, but then you'll come back and we'll adjust it just a tiny little bit so that we can check and make sure after you've awoken from the anesthesia that things are good when you look straight ahead. So that's something to expect after eye muscle surgery. And when we do the eye muscle surgery and we do kind of both eyes, or we work on the muscles that are related to the eyelid, it can make the eyelid kind of be offset. So you can see on her left side, we did eye muscle surgery and now the lower eyelid is lower. And that's why we do the eye muscle surgery before the eyelid surgery, because it changes that position and can cause the eyelid to come down or go up. So that's why we have to wait. So the third stage is the eyelid repositioning. And that's either for the upper or the lower eyelid, as both can be affected. And the main goal is to improve the comfort from the dryness, from the exposure, from the eyes being too open, and also improve the appearance. So here's a patient who had upper eyelid surgery for retraction, and there's 2 different variations that we can do, either from the front or from the back. And depending on how severe your retraction is, will determine which one we do. And usually we do both sides at the same time, and we may need to do more than one stage of the eyelid retraction because patients with thyroid eye disease tend to heal very well, and it may come up a little bit more after surgery, and then we may need to release it a little bit more. So that's kind of what to expect for the retraction surgery. And we can do it combined with the decompression surgery sometimes. Especially if you have really severe retraction, we'll do the first stage at the same time, but usually we'll wait until afterwards. Now, if you have a tight lower eyelid and you have lower eyelid retraction, it's a tiny little bit different than the upper eyelid retraction in that we just kind of release the muscle and then put in a spacer, either hard palate or alloderm or fat. And each one of them, usually we do this one side at a time, not both at the same time, because we close the eyelid for a certain period of time with a patch over it. So we don't want to put patches over both eyes and have you not see. So we just do one side at a time, spaced by about a week or 2. Okay, and then determining whether or not we use hard palate or something from a donor like alloderm will kind of be based on your comfort level. Some patients don't like the idea of something coming out of the roof of their mouth. It does take a little bit of time for that to heal. You have to get a special guard while it heals. So a lot of patients will try the alloderm or the donor graft before the hard palate, and there's other different variations that we can do with the lower eyelid. We can take some fat from the eye socket and move it into the eyelid. So there's different ways to fill in that space. So basically that is a spacer for the lower eyelid. We can also use the synthetic product that we talked about earlier in the upper eyelid and the lower eyelid. So one of the hyaluronic acid gel fillers is Restylane. You've probably heard about it. Another one is Juvederm. And so we can use that as a filler either in the active phase or afterwards if the patient doesn't want to undergo surgery more. So we can just place it in there and actually kind of just supports the lower eyelid up and also gives a little bit of volume to the lower eyelid. And you can see in this patient on the left side, he has a lower eyelid that's a little bit lower, and then when we put the Restylane in, it can boost it up and give it some volume. And that's basically what the surgery is about. It's release the muscle and give it a little bit support. And then the last stage is the cosmetic enhancement. And like we talked about earlier, the Botox and the fillers, it's safe, it's effective. The Botox basically relaxes the muscles and lasts for about 3 to 4 months. So you do have to get a re-injection every 3, 4, 6 months, depending. And the main muscles that we concentrate on in thyroid eye disease patients are these central ones here that give the angry look, and we can do that to relax kind of the face. And we can even put it around the eyes here to relax the crow's feet. So a lot of patients like this, and you can try it if you want, you don't have to. The other thing is the fillers, and there's all different types of fillers that you can use in the face. They're all different makeup of what like the hyaluronic acid gel fillers, those are reversible. You can dissolve those out. Some of the other ones last a little bit longer. The REDNESS is kind of like bone. It's a crushed up coral. The Sculptra is a synthetic product that stimulates collagen to be produced. I would not recommend it in anybody with thyroid eye disease, just because it's unpredictable. And Artifil is a longer lasting, and I also wouldn't recommend it because you may have more of a reaction to it because of the immune system than a normal patient. So I would say stick to the hyaluronic acid gel fillers if you're thinking about cosmetic enhancement, and maybe the REDNESS. So they're all different things. And we can get pretty good results. So in thyroid eye disease, the fat tends to get bigger around the eye socket. And so if it's not that bad and you don't really want surgery for it, we can put fillers around to mask that area and blend it into the rest of the face. So you can see on the picture above, he has the area of fat, but then a hollow next to it. So we just fill in a little bit and smooth it out to the rest of the face. And then in this patient, she already had decompression, she's had her eyelid surgeries, but still is unhappy about the lower eyelid position and these bags here. And so we just fill around it, and you can see it gives her a nicer kind of contour to the rest of her face. And a lot of patients with thyroid eye disease also have high metabolism, so they tend to lose a lot of weight around their face, and their eyes look more prominent. So if you just balance out the rest of the face to the eyes, it can make a significant improvement. So she just had fat placed in her face, and you can see that by matching her face to the rest of her eyes, that she has improvement of her appearance. So let's follow a patient through all the different steps, 4 steps. Not every patient needs every step, but let's take, for example, this patient. She started having the eyes coming forward, the eyelids being retracted, and then she developed double vision. So the first stage after she was stable for 6 months was the decompression surgery, where we move the eyes back. And then she had eye muscle surgery, so that's the second step because the decompression can affect the muscle position. And then eyelid repositioning, where the eyelids were brought down. And then finally, any kind of filler or Botox or any cosmetic enhancement that she wanted. So the most important thing is to be patient and wait until you're stable for at least 6 months before doing anything. And then once you get to that point, we can kind of customize each step to you. And you may not need decompression at all. You may just skip right to eyelid surgery. And this is kind of the general rule. We like to wait 6 months after you're stable from the disease to do decompression, and then every 3 months do the other portions of the stages. We can vary that depending on the particular patient and how fast you heal, but usually all the swelling and healing is the best after 3 months, so that we know that you're stable from that and then move on to the next step. And you know, again, some of the stages can be combined. So the first stage of eyelid repositioning, because it may take 1, 2, or 3 little adjustments to the eyelid, we can do some of that with the first decompression. So the last thing I want to talk about is just preparing for surgery and what to expect, like how to do it beforehand, what to expect after surgery. So beforehand, of course, we need to make sure that you're medically cleared to have surgery, and you have to set up a driver to bring you in. But the good thing is that all of these surgeries are outpatient surgeries. You come in, you go home the same day. Usually for the decompression surgeries, if we're going to take out bone, we'll have you all the way to sleep under general anesthesia. But for all the other surgeries, you're just going to have sedation anesthesia. So it'll be kind of like a colonoscopy, a twilight anesthesia, so that the recovery is a little bit better than general anesthesia. In addition, you want to avoid any blood thinners at least 10 to 14 days before surgery. So if you're taking flaxseed oil or fish oil or the omega-3s, you want to stop that because that does thin the blood significantly, as well as any other aspirin, or if you're on blood thinners for a heart condition, we ask that you ask your cardiologist first if you can be taken off of it for surgery. Other things that also thin your blood are vitamin E and garlic and ginkgo biloba, so you can stop that as well. Some patients find that arnica and bromelain help with the swelling and bruising post-operatively. So you can actually start that 4 days before and continue it 4 days after surgery. And what arnica is, it's from a sunflower, and it helps with bruising. We don't know why. You can take it, they have different formulations. There's one you can put under the tongue. There's some that they put in a gel that you can put around the skin. Whichever one you feel best with, you can use. A lot of people use the sublingual ones where they put it underneath their tongue. The bromelain is actually taken from pineapples. So you can either eat a lot of pineapples after surgery, or you could take a pill, either one. What it has, it acts as a diuretic, so it helps release some of the swelling. In addition, before surgery, you don't want to eat or drink after midnight, except if you're taking medications in the morning. You can take it with a small sip of water. Don't take your diabetic medications if you're diabetic, because you're not going to eat anything and you don't want your blood sugar to drop. So we ask that you take your medications in the morning except for any diabetic medications. So what can you expect after surgery? Well, after surgery is your time to rest, for your time to recuperate from the surgery. And a lot of patients kind of underestimate how much work they can do. They want to just go right back to work, but it may take you a few days, probably about a week or two you want to take off, just because not only the surgery, but the anesthesia, it kind of makes you loopy for a few days. So you want to just take it easy. The important thing is that the swelling and bruising that first day of surgery actually isn't the worst. It actually gets worse for a few days afterwards and then starts to get better. A lot of patients don't realize that. So I asked one of my patients this week, I said, oh, what should I tell him, you know, about surgery? Because he had gone through all of the stages up to the eye muscle surgery, and we're ready to do his eyelid surgery. And he said, well, you know, you should tell them just to expect the bruising to get worse for the first 3 days. So just remember that if you do have surgery, the swelling and bruising accumulates probably up to the first 3 or 4 days and then starts to get better. So that's something to think about. We ask that you use ice for the first 3 days. We think that that helps with swelling. Something easy that you can do is get some frozen peas or some frozen vegetable of your choice, because what it is, it's not as cold as ice, and it also conforms to your eyes very well. So you just put a few of them in a few Ziploc bags, switch them out. You can reuse them. You could eat them later if you wanted to. And they're just really nice. So when you're going through surgery, it's something nice to have around. You can also get warm compresses, these things that you can put in the microwave. Just be careful about how warm you make them. You want them warm, not hot. You don't want to burn your skin. If you don't want to buy one of these, you can just take a warm washcloth. Run it under water and then wring it out and place it on. Once that gets cool, flip it over, you know, unravel it and put it on, and that's it. You don't have to go crazy with this, but it tends to help and make you feel better after surgery. Other things to expect is that we do give you some medications to use, mostly an eye ointment. Depending on your physician, they'll give you different variations, either with or without a steroid. And basically you want to put that on the incisions and in your eyes about 4 times a day, just to keep everything smooth and healing right, because the skin actually heals very well when there's a moist environment around. When it's dry, things get crusty, and then when you take off that crust, it takes off the healing part. So we ask that you just keep everything moist with the ointment. We also can give you some pain medications, but a lot of patients don't even need the strong pain pills after the first 24 hours. So if you're not having that much pain, you can just take Tylenol. So Tylenol is easy to use. It doesn't thin the blood down like Advil or Aleve. So Tylenol is the best thing in the postoperative period. If you're having more pain, then you can take the stronger pain medications, but just remember that the stronger pain medications also have Tylenol in it, so don't take it at the same time or you can cause some problems with your liver. So Vicodin and Percocet have Tylenol in it already, so just take one or the other, okay? And again, take at least 1 week off of work, usually we say, and then decrease your activity. And that includes all activity for the first week or two, because you don't want a blood vessel to burst. That'll cause more swelling, more bruising, and it can also cause some changes to your vision. So we just ask that you don't do too much work or strenuous exercise in the first week or two after surgery. So in summary, there's 4 steps that we can do in the stable phase of the disease. We do them in a certain order because one affects the other, and we just see what you need. Not everybody needs a decompression surgery. Not everybody needs eye muscle surgery. Not everyone needs eyelid surgery. But depending on what kind of symptoms you're having and what's bothering you, we can adjust it. And then at the end, if you want any other enhancements, we can do that as well. So it's a rough journey, but we're going to get through it, and we can help you. That's it. Thank you.